about the important MCQs in the chapter of community ophthalmology. Okay, so community ophthalmology, which is usually ignored when we do live classes or we basically go for the recorded sessions, is an important session for those students who are trying to get into the AIIMS and the institutes of the national importance, because you can get one or two questions from there, and if these questions are basically attempted well, then there are chances that you would be in the top league. Also, it is very important that the community ophthalmology, the questions are having some recent changes. So the criteria for the blindness, they have changed, and there are few more indicators like the cataract surgical rate, which has come into the limelight. So these are some important things which can be asked in the exam. So myself, Dr. Vineet Sehgal, would be available for this month of June in the Let's Crack NEET PG Unacademy channel. If you have any doubts, if you want any of the guidance, you can write it in the comment section. If you want link of any of the ophthalmology chapter, okay, I am saying any of the ophthalmology chapter, if you want to get the video lecture, you can just message me in the comment section and I would be providing you the link of that unit. Okay, so I would basically tell you that before the exams, it is very important to have a good MCQ practice, and that is my aim for today, that I would be giving you 35 odd questions of the community ophthalmology and would tell you how to basically attempt these questions and what can be the answers. So are all of you are ready? Should I start the session? Okay, so before I start the session, only one important announcement for all of you, that the NEET PG preparation has become cheap with the help of the Iconic subscription. In the Iconic subscription, you have the advantage of the best learning platforms, the live classes in the Unacademy, as well as the recorded sessions in the Prep Ladder, and you would be having the 3 years. If you are a second year student or a third year student, you can basically go with the 3-year subscription only at 58,500. So see how much discount you are getting. If you want to go for a 2-year subscription, it is available only at 49,500. If you want to go for a 1.5-year subscription, it is available only at 45,000. And we have another offer. If you want, if you are an intern or a final year student, you can get it only at 40,500. So the higher is the duration, the more are the discounts for all of you. So with this, I would be starting my session today, that is on community ophthalmology, and we would be doing it with the help of the MCQs. Okay, so the tip of the day is, do not make your preparation strategy according to the others. Analyze what is good for you, your strength and weakness, work on them and reach your goal. Now what I mean from this is that the students who basically just see the interviews of the toppers may not be doing it very well. So you have to see what are your weaknesses, what are your strengths, and let's say if you are having some doubts more in some other chapter, let's say you are having a doubt in anesthesia, or you feel that you have not done the anatomy in your first year well, so what my advice to you is that give more of your stress towards your weakness as compared to your strength. You boost your strength and analyze your weakness and basically go through that. Okay, chalo, let's start our session. My first question today is, criteria of blindness in India in presenting visual acuity in better eye is visual acuity less than 6/18, visual acuity less than 6/60, vision less than 3/60, vision less than 1/60. This is the criteria which has changed now. What is your answer? So earlier the answer was different, now the answer is different. Earlier the criteria for blindness is the best corrected visual acuity in the better eye, which is less than 6/60. Now the criteria has changed, Shumam. Now it is vision less than 3/60. Okay, so the new NPCB criteria are now equal to the WHO criteria. And what are these criteria? I am just showing you in the slide. Less than 3/60 in the better eye. So see here, in the better eye. Now what I mean is, let's say if the patient A in the right eye is having 6/60 vision, and in the left eye the patient is having 1/60 vision, is it blind or not? My question is, in right eye the vision is 6/60 and left eye vision is 1/60, so this patient is not a blind vision. So why? Because the better eye is the right eye, and the right eye vision is more than 3/60, so this patient is not a blind patient. The second criteria is less than 10 degree. Remember, earlier the criteria were less than 20 degree. Now the criteria are less than 10 degree. Okay. So this means, let's say this is the field of vision. Okay, this is the field of vision and the patient can see only central 5 degree. This happens in the patients who are having a advanced glaucoma. So if less than 10 degree only the patient can appreciate, even if the vision is 6 by 36 or 6 by 60, okay, or even 6 by 18, अगर field of vision 10 degree से कम होगा, still the patient would be a blind patient. Are you getting my point, Shubham? Okay. Chalo, let's move to our next question. My next question is about the most common cause of blindness in India. Your options are refractive error, trachoma, glaucoma, or cataract. So the most common cause of cataract in India as well as in the world is, most common cause of blindness in India is cataract. Okay. So remember, most common cause of blindness in India, in the world, in the developing countries, in the developed countries, for everything the answer is cataract. Okay. Now another important thing is, if they ask most common cause of low vision in the world, so then what would be the answer? Now low vision, or I also say ocular morbidity, now it means that we are considering all the age groups. Okay, all age groups are concerned. And second thing is, we consider as vision less than 6 by 18 on the Snellen's chart. Okay, and then as Shubham have told us, the answer would be refractive errors, or I would say uncorrected refractive errors. Okay, chalo, let's move to our next question. So next question is, NGO eye hospitals make which stage of NPCB? NGO means non-government organization and NPCB means National Program for Control of Blindness. Now before I go to this question, I would be just saying you that the NPCB, National Program for Control of Blindness, this is the centrally funded, 100% centrally funded program, which basically tells you about the guidelines, how should be the ophthalmic infrastructure in our country. Okay, it tells you that there are 3 stages of the eye hospitals in India. They are the primary, secondary and tertiary. The primary means that they are at the grassroots level. The primary refers the patients to the secondary, and the secondary, then if you are having a complication or you are having some disease which is rarer, then it goes to the tertiary eye care center, which is also a training hospital for you. Okay, so my question here is, NGO eye hospital makes which stage of NPCB? Can you just do a blind guess? So like Lions Club, Rotary Club, these are the NGO eye hospitals. So they come under the secondary. Very good, Shubham, they come under the secondary. So what are the various grades? I would be just showing you. The various grades are the primary. In the primary you have the PHCs. In the secondary you have the CHCs, and in the tertiary you are having the patients going to medical colleges or the tertiary eye hospitals like LV Prasad Eye Hospital, Shankar Netralay, Advanced Eye Care Center in PGI Chandigarh, as well as RP Center AIIMS. So these are the 3 levels of the hospitals in the National Program for Control of Blindness. Okay, chalo, let's move to our next question. Next question is, which of the following is done for finding the prevalence of glaucoma and ARMD? Try to answer. So we have lots of surveys, and they basically tell you about the various eye diseases that are prevalent in India. So mass screening means everyone in the population is screened. High risk screening means that those only who have the risk factor, they are screened. Sentinel survey is something which basically is used whenever you have to assess the results of a procedure or an intervention. Are you getting my point, Rahul? So let's say you are doing a cataract surgery. After cataract surgery, what is the results? What is the gain of the vision? That is basically seen with the retinal sentinel survey. And what are the RAB surveys? The RAB surveys are called RAAB, Rapid Assessment of Avoidable blindness. Now, avoidable blindness, this is a term which is used in two criteria. Okay, so one criteria is, let's say the patient is having a xerophthalmia or glaucoma. We can avoid the blindness there. Okay, so we can basically intervene at a proper stage so that the blindness does not come. The second is preventive. So this is the preventable blindness. And then the second one is curable blindness. Curable blindness means, let's say the patient is having blindness because of cataract and we do the surgery and this blindness is reversed. This is called a curable blindness. So both the preventable, are you getting my point, Rahul? Both the preventable as well as curable, when we add them, this is called a avoidable blindness. Okay, so tell me, which one of them is used for measuring the prevalence of glaucoma and ARMD? You can just put a blind guess also. So here the screening that we do is the high risk screening. So please note my further slides. So whenever we talk about the high risk survey, we screen the population who are having a diabetic retinopathy as well as glaucoma. Okay, so in diabetic retinopathy and glaucoma, we do a high risk survey. So those patients who are diabetic, so you have to see about the diabetic retinopathy. Let's say you are doing a fundus photograph. So fundus photograph or OCT you have to do only in those patients who are having a uncontrolled diabetes, not in all the population. Second thing is, patient is having glaucoma. So you first ask the patient that, do you have any family history of glaucoma? Do you have any history of high intraocular pressure? Do you find pain in the eye? So only screen those patients. You do not have to screen all the population. Okay, this is basically used, high risk surveys used for the diabetic retinopathy and glaucoma. The sentinel survey, I told you, is basically used whenever we have to measure the results, like the results after the cataract surgery. Whether the patient, let's say patient was having 1/60 vision pre-operatively. After the surgery, the patient is having, in one eye hospital, the average vision that has got is 6/18, and in the other hospital, the average vision after the cataract surgery is the 6/9. So this is patient A, this is hospital A and this is hospital B. Both have done a 50 cataract surgery. Okay, so with the sentinel survey, we can basically see that the hospital B, the chances of getting a better vision, there are better equipments, the better training of the surgeons. So the hospital B has performed well as compared to hospital A. This is basically seen by the sentinel survey. Are you getting my point, Rahul, Shubham, everyone? Okay, chalo. Then we have the RAB surveys. I told you, rapid assessment of the avoidable blindness. It tells you about the preventable blindness like xerophthalmia and glaucoma, and it also tells you about the patients who have the curable blindness, like you are having a glaucoma, the cataract and the corneal opacity. So this is basically seen with the help of preventable blindness and curable blindness. All of you get my point? Okay, chalo, let's move to our next question. Next question is, which of the following is the cause of preventable blindness? I just told you now, so try to answer it fast. So as I told you, preventable blindness is the one which can be prevented. Okay, cataract cannot be prevented. Okay, retinitis pigmentosa, Leber congenital amaurosis, they are neither preventable not curable. Cataract is a curable blindness. Okay, very good, Haya. The glaucoma, the blindness due to glaucoma as well as blindness due to vitamin A deficiency. The word I use here is xerophthalmia. So they are the preventable blindness. Give me a thumbs up if you are able to understand this point, and please like the video if you find these points more useful for you. Okay. Now I would be just telling you about the various types of blindness, because I think that there are a lot of confusion regarding the various types of blindness. So first is 3 definitions which are there in our site in the National Program for Control of Blindness. So these are, the first one is the economic blindness. What is the meaning of economic blindness? Economic blindness is when the vision is between 3/60 to the 6/60 in the better eye. Okay, just give me a minute. Sorry, there was someone who knocked at the door. I was alone. Anyways, so economic blindness is less than 6/60, and if the patient is having the vision in between them. What is the meaning of social blindness? Social blindness means if the vision is between 3/60 to the 1/60. What is the meaning of manifest blindness? If the vision is having less than 1/60 to perception of light. Now, what is the meaning of perception of light? Perception of light means the patient is not able to see the finger even very near to the face. And what you do is you put some torchlight over the eye, covering one eye, and you ask that whether he can perceive the light or not. If he can perceive the light, this is basically called a perception of light. Then you tell the patient to see right, left, above and down. Okay, so this basically tells you about the projection of rays. So whenever the patient is having a very low vision, we write it like this: PL positive. So he can perceive the light and he can perceive the projection of rays from the top, from the bottom, from the left, from the right. So PL positive and projection of rays is accurate in all the quadrants. If you get my point, give me a thumbs up, because this is a very, very important point. They are asked in the exam again and again. If the vision is less than that, then what should be your performance? Okay, chalo. Then the next is, what is the meaning of absolute blindness? Absolute blindness is something which the patient cannot even perceive the light. Okay, so no perception of light, this is called a absolute blindness. Then, as I told you, curable blindness is when the patient had a blindness earlier, but after the surgery or after the treatment, he has got the vision back. This is called a curable blindness. And what is a preventable blindness? Preventable blindness is if the blindness can be prevented, like a vitamin A deficiency or a glaucoma. If the blindness has occurred, then you cannot do anything. But if the blindness can be prevented, this is basically called a preventable blindness. And if I combine the curable blindness plus preventable blindness, this is called the avoidable blindness. Give me a thumbs up if you are able to understand this, and if this figure is important for you, just take a screenshot and like the video. Okay, chalo. The next question is the question which was asked in the AIIMS 2 years back, and the question was, all of the following come under the criteria of the RBSK except. Now, what is the RBSK? Can anyone tell me? So, RBSK is the Rashtriya Bal Suraksha Karyakram. Okay, Rashtriya Bal Suraksha Karyakram. So, there are few ophthalmic disorders which are also included in the Rashtriya Bal Suraksha Karyakram. My question is, which of them is not included? So answer here is congenital glaucoma. So remember, the congenital glaucoma is not included in the Rashtriya Bal Suraksha Karyakram. Refractive error, childhood blindness, vitamin A deficiency, and ROP, they all are included in the RBSK. Okay, Rahul, ROP is included in the RBSK. The guidelines for the retinopathy of prematurity, they have basically changed. Earlier it was less than 32 weeks. Now it is less than 34 weeks. Any child less than 34 weeks, or earlier it was less than 1500 grams, now it is less than 2 kg. So any child which is less than 34 weeks or less than 2 kg now have to be screened essentially for the ROP. Just give me a minute. Sorry for the issues. I would be just back in 2 minutes. There was some medical emergency. So here I was telling that the ROP guidelines, they have now changed. Okay, so what is now is that the patients who are having the, or the children who are less than 34 weeks or less than 2 kg of birth weight, they are basically now coming under the screening for the ROP. Okay, now tell me, what is the instrument that is used for the ROP screening? What is the instrument that is used for the ROP screening? So it is the indirect ophthalmoscope. Okay, chalo. I would be just taking a leave for 2 minutes and would be back within 2 minutes. Okay. Sorry for the interruption, but what can do in this COVID scenarios? Anyways, chalo, let's continue with our session. That is the next question. The next question is not a feature of National Program for Control of Blindness. Your options are reduce backlog of cataract surgery, B, strengthening of the regional institutes of ophthalmology, C, increasing the community awareness, and option D is state subject. Which of the following is not true regarding the National Program for Control of Blindness? So remember, National Program for Control of Blindness, this is a totally, I told you, is a central program. Okay, it is not a state program, it is a total centrally funded program. So it is not a state subject. Okay, it is a central subject. So the answer is D here. Okay, now what are the various features of the National Program for Control of Blindness? I told you it is a 100% centrally sponsored program. So there are a few strategies which you have to remember regarding the National Program for Control of Blindness. The first one is the outreach activities. Now outreach activities, what it means is, earlier you must have heard about the iCamp approaches. Okay, so what is the iCamp approach? iCamp approach means that the patient, we used to go for the camp surgeries and there we used to operate the patients. Now what we do is we basically go for a reach in program. In reach in program, what I do is, let's say I am a doctor. Okay, I go to a tribal area or a village, I screen 50 patients there, arrange a bus for them or a transport for them, and tell them to come into a hospital. In the hospital, I operate the patient and then tell them to go back to their place. So this is called a reach in program. Okay, so now it is not the making of the operation theater in the village or tribal area we have to do. We have to tell them to come into the fixed facility, operate them and treat them, and then we tell them to go back to their areas. Okay, this is called the outreach program. Is it clear, Shubham, Rakesh? Okay, second thing is more comprehensive catering for the other causes of blindness. Now the emphasis is not only on the cataract, it is also on the refractive errors, other causes of the childhood blindness, corneal blindness, glaucoma, as well as diabetic retinopathy. So we are more comprehensive in the eye care now, and not only just the cataract is the basic focus. Also services in the rural, tribal and other difficult area infrastructure development, and appointing contractual ophthalmic manpower. That is also a new strategy for the NPCB. Now what it means is, now you have seen that in big cities, in big districts, they have multiple of the eye hospitals. But the problem is that still the blindness is more in the rural area and in the tribal area. So what the NPCB is doing is that they are basically giving the contracts to the private players, as well as they are doing it taking the contractual ophthalmic manpower. Let's say I go for a surgery, I go to a private practitioner, the private practitioner does the surgery and he gets a small amount of the remuneration from the National Program for Control of Blindness. This is called a contractual ophthalmic manpower. So not only the government but the private sector is also involved in the now National Program for Control of Blindness. Is it clear, everyone? Okay, chalo. Now there is also a new development, that the name of the National Program for Control of Blindness, the name has changed and now it is NPCBVI. Okay, so National Program for Control of Blindness with Visual Impairment. This is the new term which is used nowadays for the National Program of Control of Blindness. So if you can see here, it is not the blindness only we have to remove, we have to remove other causes of low vision as well, like refractive errors, diabetic retinopathy, glaucoma. They also have to be treated. Visual impairment also has to be treated. We have to basically intervene before the blindness occurs. Is it clear, Shubham, Rakesh, Rahul, everyone? Okay, chalo, let's move to the next question. The next question is, which of the following is not an agency for the Vision 2020 program? Your options are WHO, UNESCO, Orbis or Sight Savers International. Try to answer. So Vision 2020 program, this is a WHO associated program where few of the agencies have basically got their hands mixed with each other. They have basically collaborated to prevent the blindness in the world. These agencies are the WHO's, the Orbis, the Sight Savers International. Remember, UNESCO is not considered with the health. UNESCO is something like a Taj Mahal, Qutub Minar, heritage. So it is basically involved in maintaining the heritage structures, cultural organization. Okay, it is not associated with the health program. So the answer is B here. Okay, so what are the agencies which are there in the Vision 2020 program? Remember, they are the WHO, IAPB UK, that is the International Association of Preventable Blindness of the United Kingdom, and some NGOs like the Christian Blind Mission, Helen Keller International, Orbis International, and Sight Savers International. So these are the private sector which have to be, which the non-government organization which are also collaborating for preventing the blindness in the India. Okay, chalo, let's move to our next question. According to the guidelines, according to the national guidelines, what should be the criteria for the vision centers in the country? Now, what is the meaning of the vision centers? Vision center basically take the vision, give the glasses, power of glasses. Also, they basically deal with the common eye ailments, okay, like the red eye, like the chalazion. So these are the common eye ailments which they can basically are given a treat, and then if you feel that there are something which is require more an intervention, you basically refer it into the district hospital. This is the basic funda or the upgraded community health centers. So this is the basic funda of the vision centers. So what is the guideline for the vision centers in the country? So this is per population. So there should be at least one vision center in every 50,000 population. Please remember this pyramid. So this pyramid is basically telling you that there should be at least one vision center for 50,000 population. Okay, and one service center. So 10 vision centers basically refer their patient to one service center, okay, like a district eye hospital. Then 10 district eye hospitals or 10 upgraded CHCs, they are basically sending the patient to a training center, okay, let's say a regional institute of ophthalmology. Then we have a center for excellence. Center for excellence are like your All India Institute of Medical Science, okay, RP Center. This is the Apex Institute of Ophthalmology. Then we have Advanced Eye Centers, PGI Chandigarh. Okay, we have Shankar Netralaya, LV Prasad Eye Institute. Okay, these all come under the Center for Excellence, where the guidelines are made, where the research is taking place, and where the training of the patients is also taking place. These are the Center for Excellence. So 20 Center for Excellence, 200 training centers, 2000 service centers, and 20,000 vision centers. This is the minimum criteria that we should be having as the infrastructure goals. Okay, chalo, let's move to our next question. Next question is, vitamin A supplementation is linked to which immunization program? Your options are BCG, DPT, measles, or polio. Vitamin A supplementation program is a very important program which the central government has launched, and every child which is between less than 5 years of age, more than 6 months and less than 5 years of age, they are basically being given this vitamin A supplementation. These can be given as the intramuscular injection, or they are also given in the patients mostly as the vitamin A syrup. This is basically a program which is basically linked with the measles immunization program. Okay, so what are the important criteria for the vitamin A supplementation? I told you that it has to be given in the patients who are between 6 to 15 months of age. Okay, The 9 doses of vitamin A are given, that are 1 lakh international units between the 6 to 12 months and 2 lakh international units every 6 months after them, and it is linked to the measles immunization program. Okay, chalo, let's move to the next question. The next question is, safe strategy is used for which of the following disease? Your options are onchocerciasis, cataract, trachoma, or vitamin A supplementation. So very good. I think that all of you understand this SAFE program. So what is the SAFE program? SAFE program is under the category of GET. What is the GET? GET is Global Elimination of Trachoma. So under a global elimination of trachoma, we have made a SAFE program. So what is SAFE program? It has 4 components: SAFE. What is the meaning of S? So S means that we have to do surgery for correcting the various type of lid deformities. Let's say you are having the entropion, you are having the trichiasis. So whenever we do the surgery for that, that comes under the S. What is the meaning of A? A means that there is antibiotic prophylaxis and the antibiotic treatment. Like we give tetracycline ointment for the mass prophylaxis, and for the treatment we can give the single dose 1 gram azithromycin, that comes under the antibiotic. What is the meaning of F? F means the facial cleanliness that we have to provide, and E is the environmental changes that we have to provide. So this is the SAFE strategy, and remember the SAFE strategy is basically used for the trachoma. So the SAFE strategy, S goes with the surgery, A goes with the antibiotics, F goes with the facial cleanliness, and E goes with the environmental changes. Okay. The next question is, most common cause of blindness in trachoma is, your options are follicles, option B pannus, option C macular edema, option D corneal opacity. Try to answer. Try to answer. So the answer here is D, that is corneal opacity. Okay, so the corneal opacity can cause the blindness. The follicles, pannus and macular edema, they are not the things that can cause the blindness in the trachoma. Okay, now this is a bit difficult question. The question is, Shubham can answer, mass drug chemoprophylaxis has to be started in an area where the prevalence of trachoma is -% in 1 to 9 year of age group. Now, what is the meaning of this? Arnab, the Telegram ID is in the description of this session. Okay, you can just see the description of the session. There is the Telegram ID. Okay, so mass drug chemoprophylaxis, what it means is that if we get something like this, a prevalence more than X percentage, then we have to basically give the prophylaxis to all of the population. Okay, so this is the answer here is, as Rajesh, Shubham and Latika have told us, the answer here is C, that is 10%. Okay, so just remember. And what is the chemoprophylaxis that we would give? We would give eye ointment, tetracycline, okay, and this we have to give it twice a day BD for 6 weeks. If they ask what is the drug of choice of trachoma in adults, then what would be your answer? Then the answer becomes one of my favorite antibiotic, that is azithromycin. Okay, so this is the chemoprophylaxis and this is the drug of choice. Okay, chalo, let's move to our next question. Okay, so the next question is, which of the following is not a primary sign of vitamin A deficiency? Your options are corneal xerosis, bitote spots, corneal scar or keratomalacia. So whenever we talk about the vitamin A deficiency, we have the primary signs and the secondary sign. Primary signs means that there is a active vitamin A deficiency, and the secondary signs means that these are some manifestations which were because of the vitamin A deficiency and they have caused a permanent damage. So my question is, which of them is not a primary sign but a secondary sign which has caused a permanent damage to the cornea or towards the fundus? So very good, Latika. The answer here is C, that is corneal scar. Now, what are the primary signs? These primary signs are classified as into X1A, X1B, X2, X3A, and X3B. So what are the X1A? The first sign. The first sign is dryness of the conjunctiva. I call it conjunctival xerosis. Okay. The second is when we get some spots on the conjunctiva, foamy epithelium spots on the conjunctiva. I call it X1B. What is the meaning of B here? A very important spots in the conjunctiva, like a foamy epithelium. Can you name them? They are called Bitot spots. Have you ever heard the name? Bitot spots. Then we have X2. X2 means now the dryness has come under the cornea and this is called a corneal xerosis. Now xerosis means there is a dryness. Okay. And then we have the X3A where the xerosis has now gone into the ulceration. So there is a corneal ulceration there. This is X3A. And this ulceration have caused a thinning of the cornea. This is called keratomalacia. Okay, this is called a keratomalacia. So these are the various primary signs of vitamin A deficiency. Do you all get my point? Now what are the secondary signs? Secondary signs means those which are because of the already done damage. So these are called XN, XF and XS. So you can remember it with the mnemonic NFS, need for speed. When I was there as a medical student and in my 11th and 12th, this was a famous game that is coming in the computer, need for speed. So NFS, the first one is the night blindness. The F is when you get some whitish yellowish hypopigmented spots all over the fundus. This is called xerophthalmic fundus. Xerophthalmic fundus. And S is the scarring. Scarring, is it in the cornea or retina? It is in the corneal scarring. Okay. So because of the corneal ulceration and the keratomalacia, if you get a scarring, this is called corneal scar. So these all are the past signs of a severe vitamin A deficiency. Okay, chalo, let's move to our next question. Next question is regarding the treatment of these patients. Now the child is a 2-year-old child and the patient was also having a vitamin A deficiency. How would you treat the patient? So you would give a oral vitamin A 1 lakh dose in 0, 1 and 28 days. Intramuscular vitamin A dose 1 lakh unit for 0, 1 and 28 days. Oral vitamin A 1 lakh unit for 0, 1 and 14 days. And IM vitamin A 1 lakh unit for 0, 1 and 14 days. Now if the patient is a 2-year-old child, you have to give a full dose here. So here remember, if it is the patient is less than 1 year, you would give the half the dose. If the patient is more than 1 year, you would give the full dose. And I have confirmed it from our respected faculty, Dr. Vivek Jain sir, because there was some confusion regarding a statement that is given in Khurana sir book regarding when is the prophylaxis to be given or when is the treatment has to be given. It has written less than 4 weeks, but I have confirmed it from all the sources. It is now 0 day, 1 day and 14 days. You have to give it in 0, 1 and 14 days. We have confirmed it from Dr. Vivek Jain sir also. So remember, if there is a oral dose, so oral dose is basically 2 times the intramuscular dose. Okay, so if the oral dose I have to give in this patient, I would give a 2 lakh unit, and if I have to give the intramuscular, I have to give 1 lakh unit. If this point is clear to all of you, give me a thumbs up. So intramuscular 1 lakh unit in 0, 1 and 14 days, this is the answer of choice. Is it clear? Okay, chalo, let's move to our next question. So next question is something which is new development, which is being asked again and again. This is called cataract surgery rate. So cataract surgery rate is that it is number of cataract operations in persons above 50 years of age. It is the number of cataract operations per million population per year. It is the number of cataract operations in patient having cataract. It is the number of cataract operations per 1000 population per year. Try to answer. Just do a blind guess. Even if you have not studied this term, you can just do a blind guess here. So it is the number of cataract operations which are happening per million population per year. Okay, this is basically defined as the cataract surgery rate. The problem with the cataract surgery rate is, let's say you are in a place like Delhi. Now in Delhi there is a more of the elder population. Let's say more than 20% of the population is a elderly population which is more than 65 years of age. So definitely cataract would be seen in more this age. Now you go to a place, let's say you go to a place like Sirsa in Haryana, or any great city or a village. Let's say you go to a Peva village. Okay, now what is happening there is that the population which is more than 65 years, this is less, around only 10 to 15%. Okay, so in these population, the amount of patients who are requiring cataract surgery would be definitely less. Are you getting my point, Dr. Rakesh, Shubham? So it is not a very good indicator, cataract surgery rate. What we must be having some indicator which basically would tell you that how many patients who require a cataract surgery have got it in your district. Are you getting my point? So जिनको जरूरत है उनको cataract surgery कराई गई. This is the meaning of the cataract surgical coverage. Okay, so another term which we have basically used now is a cataract surgical coverage. Cataract surgical coverage means percentage of the visually impaired individuals. Okay, let's say there are 100 visually impaired individuals and they are visually impaired because of the bilateral cataract, and out of them 65 patients have received the cataract surgery in 1 year. So can you appreciate this is a better term as compared to the cataract surgical rate? Give me a thumbs up. If this is a new point for you, please note it down or take a screenshot, and if you think that this session is useful for you, click on the like button. Okay, so with this I would come to my next question which I have already discussed. Try to answer it fast. Apex National Institute of Ophthalmology is Advanced Eye Care, RIO Sitapur, Dr. RP Center for Ophthalmic Sciences, or Shankar Netralay, Chennai. Apex National Institute of Ophthalmology, which deals with the training, treatment and guidelines. All of them they do. So it is your RP Center for Ophthalmic Sciences. Okay, AIIMS New Delhi. This is the Apex Institute of Ophthalmology, my alma mater also. The Dr. RP Center for Ophthalmic Sciences, AIIMS New Delhi. This is the Apex National Institute of Ophthalmology. Okay, chalo. Let's move to our next question, a simple question now. Which of the following ocular diseases have been recently classified as eliminated from India? Try to answer. Onchocerciasis, infective trachoma, hemorrhagic conjunctivitis. So this is a big achievement of the National Program of Control of Blindness, the infective trachoma, not the trachoma. What is the meaning of infective trachoma? In the 1 to 9 year of age group, the prevalence of trachoma has basically decreased to its minimal level. Okay, this is the place where the trachoma is more infectious. So this has been eliminated from India. This does not mean that the adult population, which is let's say 35, 40, 45 years of age, they may not be suffering from trachoma. Okay, chalo, let's move to the next question. The next question is highest prevalence of blindness in rural India is seen in which state? Your options are Odisha, Bihar, UP or Chhattisgarh. Last question of the day. So most of you may be answering Bihar, but Bihar is not the answer here. The answer here is Odisha. So Odisha is having the maximum incidence of maximum prevalence of blindness in India. Okay, and the criteria now is to prevent the blindness or decrease the prevalence of blindness to less than 0.3% of the population. Okay, this is now the target for the prevalence of the blindness for the National Program for Control of Blindness. Okay, so with this I end the session, and before I end the session I would thank you all for attending this session. You can subscribe for our channel, that is the Unacademy Let's Crack NEET PG channel, where you would get my videos in the month of June, and also hit the bell icon for notifications of the various channels. Also you can, if you want to go into the Telegram group of the Let's Crack NEET PG, you can just click on the button here and you can basically have the link here also. Sir, Aditya, which question you want to me to explain again? Any question, any specific question? Aditya, I cannot get your question. Which question you want me to explain? Okay, so till Aditya puts his question, I would be just telling you about the Plus subscription and the Iconic subscription. In the Plus subscription, you have the advantage of the live classes, live test and quizzes, batch course and structured schedule. In the Iconic subscription, you have the video lectures, question bank 2.0, rapid revision course and handwritten notes. All are there in the Iconic subscription, which have the Unacademy learning app as well as the prep ladder. Okay, so Aditya have asked last question. This question, highest prevalence of blindness. So I told you the highest prevalence of blindness have been seen in the Orissa and Assam, and also told you that the target of the National Program for Control of Blindness is to decrease the prevalence of blindness to 0.3% of the general population. 0.3% of the general population. This is the target now. Is it clear, Aditya? Okay, chalo. So I will be just telling you about few of the important courses which the Unacademy Let's Crack NEET PG have started. So there are 4 batches for you. This is the NEET PG Seasons 1 batch. This NEET PG Seasons 1 batch has started, would be starting from 16th of June. Here there are 3 seasons: the high yield topic revision session, the test and analysis and the previous year question session, and the image discussion season. There will be 3 grand tests, live interactive sessions, and the new NEET PG pattern questions that would be given. The top educators all over the country would be teaching you about this in the NEET PG season batch. Then you have a target next 2022 batch, where also the top educators would be teaching you with the live interactive classes, as well as you would be having the PDF notes for the session. If you miss a live class, you can have the access to the recorded sessions as well, and there would be a clinical integrated approach with the test series also included in the target next 2022 session. Then we have the MBBS Professional Year 1 batch, where Dr. Ankit Khandelwal, Dr. Naveen Porwal and Dr. Karthikeyan would be telling you about the subjects which are there in the first year. Then we have the MBBS Professional Year 2 batch also starting from 16th of June, where Dr. Cheshta, Dr. Sandeep and Dr. Arvind Arora would be teaching you about the important subjects which are the short subjects in your MBBS Prof 2. Then we have the MBBS Professional Year 3 batch, which have in the ENT Dr. Sanjay Agrawal, Dr. Sita Sudaraman would be teaching you about ophthalmology, and Dr. Neha would be teaching you the community medicine. It would also be having a very important sessions for all of you. Okay, so with this I end the session. If you have any doubts in any of the question, you can just ask me right now. Okay, and also please join us for the free grand test for the NEET PG, which is scheduled today on 20th and 27th, that is at 2:30 p.m. Okay, also as I told you, there are lots of batches and you can use the code, that is my reference code. What is my reference code? That is OPHTHAL10, to basically get a 10% discount on whether you want to go for a plus subscription or you want to go for a iconic subscription. The plus subscription would have the live classes, weekly test, unlimited access and structured course, and the prep ladder. When it's added here, then it becomes the iconic subscription. Okay, so thank you very much for attending this class. Good night.